keep you awake. And thank you, G-SPARC, for giving us the opportunity to share our experiences in conducting the Antimicrobial Stewardship Program and our flagship program on Diagnostic Stewardship. As you all know, antibiotics are the greatest discovery. Antibiotics are the greatest discovery of this century, and ever since first penicillin was discovered, we had thought that we have taken care of the infections. Ever since we had a golden era of antibiotics, one after the other new classes of antibiotics were discovered, but now we feel that we are in the post-antibiotic era, and all our achievements in controlling the infections and even doing the specialized tasks like doing surgery, transplants, cancer treatment, all this has been possible because of the use of antibiotics. But since we are already heading towards the post-antibiotic era because of the overuse, misuse, underuse of these antibiotics, many a times we feel that we are in a situation where the antibiotics are not working because the bacteria have developed resistance, and seems that it doesn't seem, it is actually a reality that the bacteria, the germs, are smarter than us. They have remained one step ahead of us. We have developed new antibiotics, they have developed mechanisms to resist, defend themselves, continue multiplying even in the presence of these antibiotics. So we started with the Antimicrobial Stewardship Program. When we were doing these programs, we have done several batches so far, trained a good number of people on this stewardship practices, and we learned that most of the time these antibiotics are used just in case that this is a some bacterial infection, so we should be using antibiotics. So although we know situations where which can be clinically diagnosed and are most of the time viral in nature, but still because they could not clinically differentiate between a viral infection and a bacterial infection, so they use it. So that's where we thought perhaps we need to get to the root of this problem. Why are they not able to distinguish between a bacterial and viral infection, and why do they need to give a broader cover here? We thought of having a program on diagnostics, and as such we know that 50% of this overuse of antibiotics is because we haven't made. Can I have the next slide? Not able to. We have this various kinds of diagnostic errors: misdiagnosis, incorrect diagnosis, delayed diagnosis. TB is a very good example. We are not able to diagnose in time, and particularly when the patient is having atypical presentation. So delayed diagnosis, this can worsen the patient outcomes and increase healthcare costs. Overdiagnosis is on many occasions, which would be because we are overdiagnosing, we have used some test which is not very specific but very sensitive, would lead to unnecessary interventions and anxiety for patient. Another example for this, use of antifungal agents. You will find both underuse and overuse. Did I do something wrong here? Underuse and overuse of antifungal agent is another example. Misdiagnosis, when we start treating viral infections with the bacterial, thinking that this could be streptococcal infection in case of sore throat. So these are some of the various forms of diagnostic errors in healthcare. Okay, while I was surfing through the internet, and I landed on a website. This is a law firm website, and I was intrigued to read the heading of this. Diagnostic errors are the most common reasons for medical malpractice claims involving children. That was, we are using these diagnostics, using antibiotic, and somebody is it's a business for them, because most of the time this is because we fail to make a diagnosis, people think that this is a medical malpractice and they sue their clinician for this. And there were other newspaper articles. I don't know whether you can see this, but there was another news report which revealed that 7% of the hospital patients experience some or the other diagnostic error. In another study, they said, we all experience in our own day-to-day practice one or the other diagnostic error in 1 or 2 months. So that's the extent or the magnitude of the problem that we have. And if you deeply look into it, medical errors or the medication errors that we keep talking about all the time is just the tip of the iceberg. Down below, at the bottom, at the root, are the diagnostic errors, and they have huge magnitude in terms of number of people affected, the economy affected by doing these tests or correcting or making up for these errors. There is a huge impact of this. And of course, this is a patient safety concern equally that we're concerned about. Now, as you go deeper into this, it sounds very simple that we day in, day out, we keep making diagnoses, treat patients, our patients are getting better also. How do you say that our patients are not getting better? But if you look at the, if you understand the complexity and the impact, you would realize the patient safety concerns that are being raised. Incorrect or delayed diagnosis, misinterpretation of the data is a very important factor, because when we misread test results or clinical information, this can mislead the treatment decision. Inadequate communication. This is both ways, between provider, between the lab and the clinicians, and between the patients and the doctor. If we are not able to communicate properly, things can go wrong. Then factors in diagnostic stewardship. Certainly you all know that samples are collected, microbiological samples are collected, sent to lab, and there is a process involved in patient selection, how you take the sample, how do you store the sample, how do you transport these samples, and then there are analytical, post-analytical factors. Of course, the last one, patient identification error. If we mislabel the samples, of course, things will go wrong. Most often we see that these samples the labels are made in the nursing station, which is a very, error-prone activity. Ideally, it should be made at the bedside to avoid labeling errors for these patients. So, if you do the Pareto analysis of the causes, you will find cognitive biases. Many times we are just, so fixed in our ideas. The first thing that comes to our mind, or the first test result which comes to us, we start then fitting everything into that line. And, and that is called anchoring bias, context error, premature closure of the diagnostic process, miscommunication, lack of experience or overconfidence, insufficient time with the patient, high workload, time pressure, and information overload. These have been found. And again, I found this on this website, on this law firm website. So, but besides these factors, there are many other paradoxes that surround the diagnostic. Be it early diagnosis versus accuracy, broad testing versus targeted testing, high sensitivity versus low specificity, antibiotic stewardship, where you start treatment, empirical therapy where you start with the broad spectrum, and antibiotic stewardship strategy, we say that you narrow it down as far as possible. Then clinical relevance of something that we grow in the lab versus colonization. Is it worth treating or not? Asymptomatic carriers, should they be treated? Versus disease spread. Typhoid carriers are one of the examples. Old versus new diagnostic. We have traditional microscopy, which is still useful, but we have now new diagnostics, this PCR and all that. I'm not very good at this. My microbiologist friends, they know it all, but a lot of things are available. Then point of care versus lab testing, which one should be used? Then test interpretation versus clinical context. Now, above all, there is one more paradox which I did not write here. Our past experience versus the present evidence that we have. Many a times we stick to our past experiences and we forget the current evidence that have because of this we may have a lot of problematic misconceptions. We have a feeling if this diagnostic test will determine the presence or absence of a disease. When we find a diagnostic test positive, we feel, okay, we have done our job and it is over. And if it is negative, it makes the disease unlikely. Whereas we know an infectious disease test can be negative when a person is truly infected. So we need to keep this, rarely, we consider the common causes, storage, transport, how we prepare our patients, or timing of collection take into consideration before we interpret these tests. So other contributing factors are inadequate patient history, poor communication, as I said, cognitive biases, failure to follow up patients. If you find an abnormal test and if you don't follow up these patients, you find something wrong on the cervical pap smear, but if you don't follow these patients, so again things will go wrong. You could have picked up this at an early stage, but if there is no follow-up, we are going to lose these patients. And of course, when we have made so many advances here, still a lot of places, a lot of areas where these simple diagnostic tests like culture and sensitivity even is not available. They have to outsource this, and they get a report after a week. By the time it becomes redundant. So, even if it is available, there are a lot of issues surrounding that. If you administer antibiotics before taking the microbiological sample, and even if you take the right sample, for example, blood culture, we find that it has a very low yield because there are many factors involved in getting a good blood culture and report. The number of sets that you collect, order of draw, the amount of blood in it, all that, and we find that there are all the time there are articles on the internet which are telling, can we go by cultures in sepsis or not, or do we need better tests for that or faster tests for detecting sepsis or not. Now when it comes to interpretation of reports, we need to think of three things here. Is the test appropriate? Has the test been taken? Vidal test, when we do right in the beginning, first week of the fever, we know that it is going to come out to be negative. Or high titers, what in an endemic area, what does it mean? Doing Montus and IGRA for diagnosis of TB, these are good tests for screening, but many times even we find that people are using this for diagnosing tuberculosis. So then even if we have chosen the right test, then we have to look at, is report clinically relevant? Is the culture and the organism grown is relevant for that site? And the culture and sensitivity done, the testing done for the drugs is relevant or not? Then third aspect is report clinically significant? We all know 10 raised to the power 5 is significant, but many times since something has been grown, if we don't look at the colony count and the people start treating these patients, so we need to interpret this report and do that. So there are, to be able to do this properly, we need to look at the pre-analytic, analytic, post-analytic factors. Amongst the pre-analytic, these are the key elements which will influence the diagnostic accuracy. Patient preparation, specimen collection, test order accuracy, patient identification, and monitoring specimen condition. Many times we suspect or there is a delay in transfer of these samples to the lab, whether the sample should be refrigerated or kept at the room temperature. Many of the time people don't know. And one common practice for urine culture, nursing, with due respect to them, they say first void urine should be collected and patient gets up at 5 and that the sample will be transported to lab only at 11 or 12 and this will be kept at the room temperature outside. So then people wonder, why are we getting no growth or why are we getting colonizers here in their growth? These are the factors that we need to look, take into consideration. Then, of course, the analytical factor, the assay, the instrument, the quality control, centrifugation, all this will affect the accuracy of the diagnostic. I'll not go into details because I'm not a microbiologist, and I believe that they do take care of these in the lab as far as possible. Now, post-analytic is very important because this will affect the accuracy as well as the efficiency. Result accuracy, is there any transcription error? Reporting format, are they conducive? They facilitate understanding or not? Feedback mechanism. Do we get feedback from the patients or other physicians or this or not? I think this is something which is missing, and turnaround times is very, very important. You give report, because you have to take decisions at the bedside, and if you are getting report later, perhaps not going to serve the purpose. So these turnaround times to be decided very carefully. And of course, all this can be sorted out by having a diagnostic steward. But can you consider this diagnostic stewardship in isolation? To be my belief, it has to be integrated. You cannot separate out diagnostic stewardship from antimicrobial stewardship because they are in continuity. The continuum of care demands that you make the right diagnosis at the right time for the right patient and give right medicine. So that's what about diagnostic stewardship. So in 2022, we started a program. First, because of the ongoing pandemic, we did it online for the doctors as well as nurses and lab. There were two separate programs for them. Then we started doing, once the pandemic was over, we started doing physically. Here in 23, we held the first diagnostic stewardship program in physical mode here in Hyderabad in collaboration with Dr. Ranga Reddy, and we were very happy to see the response in this region of the country. We had 225 participants coming up, and this was the first of its kind forum where clinicians, microbiologists, pharmacologists, pharmacists, critical care, surgeons, all of them came together in one forum and discussed their problem. This is what is about. Since then we have had 5 physical programs, and more than 1,000 doctors have attended this. We did the assessment of the participants. The idea was to find out which are the areas which need to be strengthened. If we know the gaps, then we can address these. Those in the circles here, you can find the baseline knowledge was not adequate, but it improved significantly after the program. I'll not go into the detail of each of these, but we had tests for all domains which covered all domains of the diagnostic stewardship. Again, here for the clinicians program, we found significant differences. But when we looked into, pre-analytic, when we divided these themes into pre-analytic, analytic, report interpretation, you can see there were areas where the baseline was quite low and which needed to be strengthened. Educational programs. Awareness about the diagnostic stewardship was low initially, then people started understanding it, but still it wasn't up to the mark. Most of these people had this idea that testing is what is about diagnostic. Doing the latest expensive PCR or genetic testing is the answer. But in the stewardship, we talked about both underuse and overuse, the traditional microscopy versus the latest technology. These were areas. And then many times people didn't know, they knew what to do, but they did not know how to go about it, how to implement these things, about the AMS actions, particularly drug and bug combinations, which should be used, which should not be used. This was another area where there was a lot of need to improve upon. So of course, the relation, as I said, it is the continuum of care, so you cannot separate them. Then there are, in this program, we talked about the strategy to improve upon diagnostic, right from the nudges, comments, best practice alert, how to collect samples, we covered that. Then removal or inclusion of a test in the battery, stop, auto stop, reflex testing, selective testing and reporting, cascade reporting, result suppression, and best practices. These were the strategies that we talked about during this program. And of course, feedback is the most important, and I think in my 30 years of experience of doing these programs, I find we do a lot of good work, but we don't share it with the end user, and we don't get their feedback. If we have forums where we can learn from each other, exchange our ideas, get our doubts clarified, things will improve a lot on their own. You don't need very sophisticated interventions here. Just simple, presentation, audit, and feedback that will solve many of your problems. Then, of course, in these programs, we talked about the best practices to take urine culture, blood culture. In blood culture, very often we found that, people thought just 2 or 3 ml of blood is enough, whereas we know that you need 10 ml blood. So why yield is coming so low? It is because the inadequate volume has not been covered. Like this, we talked about all of the best practices in various culture. And stool culture, this is another area, Clostridium difficile. Over testing is done. Then people don't know how to select patients. For example, criteria like if you don't accept samples if the stool is hard or if the patient is on laxative, then these are not the right patients for this. Fungal, we also had a session on antifungal diagnostic, because overuse of antimicrobials is one of the key reasons for fungal infections in the ICUs, and we are losing these patients because we don't have many antifungals, and they are very difficult to eradicate. Once the patient is Candida auris has emerged, and once the patient is infected with Candida auris, nearly all your patients are going to get this fungal infection. So we talked about antiviral stewardship, we talked about anti-tubercular stewardship programs, and of course last session had been, how do you evaluate whether your program is working or not? So we developed indicators, we collect, how do you collect data, interpret this, give feedback, and then re-evaluate, allocate resources for this. And of course, this diagnostic stewardship can also help you in developing the infectious disease diagnostic. We need more of point of care testing. So, the pharmaceutical industry would also know where to invest, where is the gap area, so they can come in. And of course, all these steps, while ordering, collecting, processing, reporting, there need to be indicators for this, and we need to, take care of the gaps in these areas. We have a triple shield here: IPC, infection prevention control, antimicrobial stewardship, and diagnostic. And if we use these 3 shields judiciously, we can contain this problem of AMR. So there are, few tips that can help avoiding these diagnostic errors. Most of it is actually clinical judgment and critical thinking. Taking good clinical history and examination. There are no shortcuts to this. Today I think most of us have gone into era where we do not touch patient, or we do not take good history, no touch technology. I think that's not going to work. We are working in a profession where we need to talk to the patient, take a good history, examination, improve our communication. and collaboration with other experts, then be aware of diagnostic pitfalls, overdiagnosis and underdiagnosis, do a follow-up, avoid over-reliance on test results, prevent confirmation bias. This is we don't realize this, but this is, we were talking yesterday, we have enough of evidence that stewardship works, that, all this IPC works, but still people are not following. My suggestion was perhaps then we need to talk about behavioral change theories now. How do we change the behavior? What are the drivers? Dr. Vijay Yalandi has been talking about the accelerating factors. What is it that which is accelerating? We need to look into this, and you see that these are interpreted. I think you don't need fancy diagnostics, just you need humility and curiosity. What is it that the patient may be suffering from? How is it that I can help this patient? Just if you have that keen eye for the condition of the patient, it will solve many of your problems. Checking it twice if you are not sure, use checklists and other things, and produce this, do this co-production. I have seen people saying diagnostic tests cost about 1,000 rupees and the antimicrobial treatment cost is just 400, 500 rupees. Better start treatment with antimicrobials only. After doing the test also, you will be given antimicrobials. That kind of rationalization is there. But whereas in stewardship, we promote that targeted treatment as far as possible. Be specific when you are using these antimicrobials. And one of my favorite examples is, you need to, whenever you are in fight or war, you take out your weapons from your armamentarium according to the degree of the fight. Right away we take out our sword. Broad spectrum antibiotics are like sword. We right away, without even a slightest indication, we take out. Whereas we can work with simple needle, we can work with simple incision and drainage. We don't debride the wound and we start treating these things with antibiotic. I think we have over-relied on the power of these antibiotics. We need to, think again, because our pipeline for new antimicrobials is running dry. Today we had a session on Enmetazobactam, which is first India origin discovery of a new antibiotic. But I'm taking it with pinch of salt. How long are we going to preserve the effectiveness of this new antibiotic? Use them sparingly, effectively, so that we can prolong life of these antibiotics. Because antibiotics are certainly a different class of medicine. They are not like paracetamol. They are not like antihypertensive drugs, where they will have effect on the individual patient. Individual use is going to impact the community use. So be careful, be mindful. I have heard people saying the individual patient right in front of me is more important than the community or the AMR in the community. But here is the trick, that we need to strike a balance between individual and the community use and prolong and preserve this precious resource for future generations. Thank you.
Lecture and information that the laboratories have to really be upgraded and they have to do their job, including not only the mutual thing that the clinic and the labs work together. Any questions?
Dr. For the Diagnostic Stewardship Program, I not developed a diagram which was well started. Much we have come across many times asking for wrong, right? So I think stewardship has more inclined towards the clinician than the lab doctor. If you are to be honest, like many times we are doctors start an aminoglycoside positive or MRSA positive. So I have felt a lack of knowledge gap more wider than the lab doctors. So definitely lab doctors give advice about more of the clinical involvement.
Yes, the lab both have a role. Let's not get into that who has major role. Of course, are going to use these lab reports. So it is for them to utilize them effect. But how, when you talk and they said, oh, they are not growing anything, they just give no growth or mixed growth, or they are reporting, drugs which are not meant for this kind of bug. There are lots of questions. When when both of them together, all these is sorted out. One more thing, definitely this is a very important area into the curriculum. How far is this covered? When we looked at the AMSP part, although this has to the undergraduate curriculum, but only it accounts for 1% of the total competence. So the effective time, and most of the time antibiotics are presenting today on 1 in 3 patients, 1 in 5 patients. Here 80 to 90% are treated with antimicrobial, whether they suffer from some infectious disease or not. This is considered. All normal delivery patients, they get cefixime as a package, pantoprazole, diclofenac, there's 3 combinations. So then we looked at the diagnosis. This is even not touched in the undergraduate, although microbiology curriculum does cover this, but look at the broad special, this is not covered. It is covered in the infection grant. So of course curriculum also be synchronized. Today is required to take some time. So I think meanwhile, while the next generation with the new curriculum come, strengthen our pre-service training programs, awareness programs, as diagnostic.